these two seats.
I usually wear pants.
All right, I have the privilege of moderating this last panel. I am privileged and honored to be in the presence of such powerhouses right here. So we have Dr. Virginia Kane and Silvia Shubert. Yes. So we'll have you introduce yourself, but we wanted to just get right into it. As we ask the question, you can go ahead and introduce yourself first. So Dr. Kane, got a long, rich history. But this year, you said, as president of the National Medical Association, this year you mentioned that obesity is gonna be one of your top priorities. Go ahead and level set today's conversation with why that is. Why is it gonna be a priority for you? And what do you hope to achieve this year?
Well, let me just say, I'm the Director and Chief Medical Officer of the Health Department in Indianapolis, Indiana, the largest health department in Indiana, but I am a bug doctor. You know what a bug doctor is, right? So I'm an associate professor of medicine in the Division of Infectious Diseases at Indiana University School of Medicine, and I practice out of the, I want to say, the fourth largest public health hospital in the country, Ashkenazi Health. And I see a significant number of patients who meet the obesity criteria in terms of my consults. But let's be personal. My mother died of a heart attack, and we didn't realize she had had a prior heart attack. She was diagnosed with the heart disease at her second heart attack, when she developed congestive heart failure. And we know that heart disease is the #1 killer of every race, every gender, male or female. And so when we look at the increasing rates of diabetes, I'm seeing in teenagers now. We used to see adult onset diabetes like in your late 40s or 50s, and now as young teenagers, young adults are developing type 2 diabetes, not type 1 diabetes. And so it's been a major concern. And so if we could address obesity, I could knock out those complications of a heart attack by maybe 30%. I could reduce diabetes. Oh my goodness. Or whether it's hypertension, lipid disorders, and so many other complications related to it, even impacting infant mortality. I think this is the way to go, where we could see some very rapid intervention that will make a huge impact across this nation, but especially for people of color.
Awesome, awesome. Silvia, to build on this, can you discuss some of the misperceptions about obesity as a disease? And what do you think some barriers are?
Yes, thank you. Hi, everyone. I'm Silvia Shubert, and I'm currently the Vice President, U.S. Head for Obesity Marketing at Novo Nordisk. And I'm very humbled to be sitting next to you, Dr. Kane, but I have a lot of similarities to your story. I have many people in my own family, including my father-in-law, who lives with obesity. And I do remember when I had met him 20 years ago, we were talking about getting him gym memberships and trying to change his diet. And I didn't realize really obesity as a disease. And I've been in this market for about a year, but this is the most amazing opportunity for us to improve population health around the world. And the fact that we can do that, and the fact that only 94% of Americans still who are suffering with obesity aren't on medication. It's only 4%, which is hard to believe. in all of the social media that you see that we still have really under treatment for this disease. And the fact that it has almost 200 or so comorbidities associated with obesity. To your point, cardiovascular, and where there's a lot of disparities, obviously, is in the Black community. And right now, the average patient on these types of medications are female, 47, BMI of 37 or greater, and white. And over 50% of our Black community are suffering from obesity. So there's such a huge opportunity to really do much better.
Can I pipe in a little bit here? So one of the other things I think is so important is that when we look at just the USA, that by 2030, the year 2030, over 50% of the US residents will meet the criteria of obesity. But if you're a Black woman, we're already currently, 58% of us are already obese. Now, this is the first time I have to admit that a male may be superior to a female. This is tough for me to admit this. But only 41% of Black men are obese compared to 58% of women. That's because we're doing too much of a good job taking care of you and maybe not as much for ourselves. I don't know. All right. We need to talk about this.
Right. But Dr. Kane, the interesting thing is, though, that the most underserved population, though, between men and women is men. Because men do not feel comfortable talking about obesity. And that is really an underserved population as well. And you had asked me the question about access. And obviously that's critically important. And we all know that, you know, trying to shape the policies to ensure that we have access to this medication. So it's unfortunate that the government has made a decision not to cover these for the Medicare population. And because this is a chronic condition, you can't stop the medication for someone who goes from commercial or his non-Medicare to Medicare, you know, so it's unfortunate. So we have to do the best that we can to influence our congressmen, our federal government. Thank goodness that the Medicaid still has the ability to make decisions at the state level because we have great coverage, but there is so much opportunity for us to make sure we have access to everyone.
Yes, and I love that those personal stories that you also shared, as well as those incredible goals, you know, that we can make a difference. But to keep the conversation going, what kind of progress are we making in removing some of the shame and the blame when it comes to when it comes to the negative perceptions of people with obesity? Are we making any kind of progress there?
Well, I think we definitely are. But I think a lot of our healthcare professionals have a major responsibility of understanding people's perceptions of their body images and what they perspective related to that. And we can unconsciously label someone who may be very sensitive to the issue of weight and don't want to really talk about it. So depending on your level of expertise of being able to talk about the weight without it being a negative connotation is really huge in terms of addressing this issue. And so we have a lot of training to do. Look at all our medical students coming through the ranks, our residents, our faculty. So we really need some training how to talk to folks related to if they are overweight.
Silvia,
Yes, you bring up a really good point, and a lot of it does start with the words that you use, Dr. Kane, and which I learned a lot in being in this space for the last year. But for example, and a lot of, you know, even us as friends and colleagues, because we all have people that are suffering with obesity. So it's things like, you don't say someone is obese. You say someone is living with obesity. You don't talk about exercise. You talk about increasing activity level, because exercise, for example, implies like you have access to the gym, and there's barriers to care there. You talk about things that making healthy food choices versus being on a diet, because a diet implies short term, and it is around incremental changes. And so these are very subtle conversations, but we work really closely with Queen Latifah, and we do some work to talk about how word matters. And we have like these little 30-second clips that talks about how people don't recognize the way that you talk about it. Then people don't want to seek care. Even when they get on and medication, they're still embarrassed to be on the medication, and they hide it. And people in the room, I've had this with my father-in-law, who's now on a medication, and someone said, "Oh, well, I lose weight the right way. You're losing it the easy way." And because it's not a conscious choice, it has nothing to do with will. It is a disease, and we have to treat it seriously.
I'm so glad you mentioned that. There are so many conversations that are being had right now where people may be on the medication, but they're afraid to talk about it. They don't want to talk about it with anybody else because there's that shame there. But Dr. Kane, you were about to say something?
Yeah, so, you can lose anywhere from 5 to 15% of weight loss, and we'll have tremendous dividends in terms of better health outcomes, whether it's heart attack, the onset of, if you're pre-diabetic, onset of diabetes, and so many other complications. But I also think you got to know who your audience is, who your patient is. So if I'm coming from some inner city area where, wow, crime is rampant, or it's at a higher area, wow, there's no street lights. So I may want to exercise as it's, I get off work and it's getting dark, but no street lights. So, if the car don't hit me for a hit and run, I may be concerned about the mugging. And of course, I don't know, have you been looking at some of these membership fees for fitness? And so our average person who may be below the poverty level line is not going to be able to access that. And it is so tough to hear providers say to their client, you should be eating these healthy foods. And I don't, implying that you're not. And yet maybe the closest grocery store is 5 miles away. It's winter. I got to get on a bus with my kids. Takes me an hour to get to the grocery store if I get a good, healthy grocery store for food insecurity. But then I can only buy so much carrying in those grocery bags in order to get home. So a lot of times people may be stuck with going to their gas station or places like that where there may be some food in there, processed foods, but no fruits and vegetables. And so it's so disturbing to the patient that I got a provider trying to educate me, teach me, and don't have a clue what my lifestyle is and what I'm going through. It's like a wasted breath of discussion with this provider. Wasted time. And so we've got to do better in terms of what we're offering.
Silvia, you talked a little bit about this earlier. What should we say to other folks? Like, some people use this under the guise of the body positivity movement, disagree with using medicines that can really help them.
Well, yes, that's a great question. Obviously, we want to love the body that you're in, and that's really important, that you feel comfortable no matter who you are. But it is about health. And I think it's not just about weight loss, which is what we all talk about. That's what society cares about. You see it on, every award show, every comedian's talking about it. Everybody's talking about it, about weight loss. But what's more important, and what I would say is, if you care about yourself, you care about your health. And to your point,
does anyone question about taking their blood pressure medicines if they got blood pressure? Do they have a problem about that?
No.
Do they complain about it and whatever? Please. So what's the difference in terms of having some help with your weight? But definitely believe this. We got to have a holistic approach. So it's not medicines alone. We want to try to build in that physical activity. We want to have someone eating nutritionally correct. We love the comprehensive, holistic approach in order to make a difference.
And Silvia, that's what I think you were talking about, us normalizing the conversation. That's what we're talking about here. And the work that you're doing is helping to normalize that conversation around these important areas. So another question that we've got here. What role does responsible social media engagement play in shaping public perceptions and combating misinformation about compounded treatments?
Well, first of all, there is a ton of information out there. You can't not be on Instagram or Facebook or YouTube or up on the side of a bus not to see information about all kinds of weight loss medications. And this is an unfortunate thing that has happened, that the law has allowed, up until the next couple months, compounded medicines to be distributed because it's not safe, it's not regulated by the FDA, there's no quality associated with it, and people do not know what they're putting into their body. And in fact, we've done studies, and this was in our global colleagues in Denmark, where they've done samples of these medicines through Hims and Hers and companies like that. And they have found a couple of different things. One, some didn't have any active ingredient at all. Another had 4 times the active ingredient, so people are overdosing. And then others had impurities that are banned by the FDA. It's just not regulated and it's not safe.
So let me give just a slight different perspective, okay? So we had a period of time where we had 2 major pharmaceutical companies may have had a shortage in being able to provide those medications out there to the community. And maybe there were some individuals out there based on their weight and whatever, trying to determine, okay, I may not want this bariatric surgery. And so the FDA gave a temporary approval for these compound drugs to be used until the pharmaceutical company said that they are back to where they are, where they can manufacture the drug and get them out in a sufficient fashion that we no longer have to use medications that have not been academically studied or researched. So, you know, pharmaceutical company tries to make the drug based on the ingredients. It's just like the cook. And I got the recipe, but will it be the same? But that was the purpose as a temporary help. But since then, now that the manufacturing is where it should be with these weight loss drugs, and these drugs have been rigorously studied. They've been studied for a long time over in Europe, and now more so here recently. Then the FDA said in good consciousness, we can no longer recommend any drugs that have not been rigorously studied when we have the real thing here and we don't have a deficit. And so that FDA approval stopped actually last month and this month. So just so you know.
Yeah, and thank you, Dr. Kane, and that is a very good point. The other thing is that compounding is still going to be appropriate for certain patients. There are individuals who need other things, you know, different doses or whatever. So there will always be an appropriate avenue for patients to do that. So it's not totally stopped. But you bring up a really good point. But the whole social media.
But now they're cheaper, the compounds. So I need you in the industry here to figure out that very good way for people who meet the poverty level or below, need to figure out a way how they can get access to their drugs. Because we don't want this to be like the designer drug only for the rich. You know, folks got money and got access. So I need us to all come up with a great solution so we've got equitable care out there. I'm not supposed to use that word equitable, right? I think, you know, someone said something about that.
But I think you're saying something that we've been hitting on we've been hitting on all day about just the collaborative spirit that we're talking about, just like you just mentioned, all come together to figure out, what can we do? Because this is something that my family suffers from. I'm sure many of the people in the audience here, we've got family members that suffer from it.
If I can cut heart attacks, I can get rid of heart attacks by 30% almost in this country, 30%. Do you know that the average age for a Black male's life expectancy is 68 years of age? Did you know that? Women, this is where we are superior. We live a little bit longer than the Black male, okay? If you are a Black female, okay? White females even longer than both of us combined. But it's so critical. We could save so much money economically. The quality of our life would be significant. I can spend more time with my grandkids. Please.
No,
Go ahead. I'm sorry.
yeah, you bring up a great point, Dr. Kane, and access and affordable care is something that we all can collectively work on. And as I was mentioning earlier, I mean, the good news is that at least from coverage standpoint, we're continuing to see more and more states cover it. And we have, right now, at least I'm aware of 23 Medicaid states that have covered it. We have 3 states that are covering teens, which is not enough because we know that we have children suffering with obesity. And so we can really prevent, to your point, that care and their negative health outcomes in the future. And so that's really what's going to be important. And as we continue to push our legislators, I think we can collectively work on that together. But you bring up great points, and that is something that we continue to work on to make sure people have access to our medicines.
I'm going to hold you to that.
Yes, you can. You can stay in touch with me anytime you want.
All right, we've got time for one more question.
Oh, it's went so fast. Okay, go on. Okay.
So this is for both of you all. So what is the most important message you want the public to understand about GLP-1s and the broader landscape of just weight management in general?
Well, for me, the number one thing is we have used these drugs in diabetes patients for years, very safe, very effective. And now we find that it's a wonderful tool that can also address obesity, but it's going to improve the quality of your life, even just a simple walking with your weight based on the impact you have on your knees, your hips. And it's just an amazing medical innovation out there that, we can't stand still. I don't want to go back to the medical world 20 years ago. We're making some astonishing scientific discoveries, and we really got to build on health literacy, the education piece, and that's the problem with access to care, because you don't always have access to good, accurate information, not the misinformation from your friends, your buddies, your colleagues who may not know, but we have to really increase our communications, our campaign out to the community, and then showcase with storytelling those folks who had this intervention and just are living so much of a healthier life, and they're living longer.
Silvia?
I mean, there's so many things, but I would say definitely continue to educate the world about obesity as a chronic disease, because yes, making the medicines available, continued innovation, we need that, but until we can do that, people will not get treated. And so I see it as that is a major thing we have to do together. And then the second thing is, I know everybody talks about weight loss, and yes, it's important, but what's more important is the impact that you have on your health, and especially around cardiovascular disease, which is prevalent among all of us in this room, in our families. So to me, that would be kind of the bigger thing for me that I'd want people to take away from.
Generations, generations, generations.
Well, thank you both for joining me. I think Dr. Kane mentioned it.
Now, when I'm 20 pounds younger the next time you see me,
Yes, ma'am. Yes, ma'am.
it may mean I may have some additional help
Okay.
besides
That's all right.
but that's okay. All right. I want you to look for me now. In 4 to 6 months. I'm just teasing. I have to do it the hard way, but that's okay.
Now, I think you mentioned it just recently. You said we can't stand still. And that was something that I started off this day with. We can't stand still. And, you know, Silvia and her team at Novo Nordisk, they're not standing still. You know, the National Medical Association, you all aren't standing still. We're still pushing this thing forward just to increase health outcomes for the patients that we serve. So I want to thank you both for all the work that you do.
Thank you. All right, that means each and every one of you are going to be responsible for cutting heart disease by 30%. And we can get those results in the next couple of years. Thank you.